I'm a neuropsychologist by training, and I run a practice that's based out of Sarasota called Comprehensive Med Psych Systems. We have about 100 or so clinicians, including about 20 plus psychiatrists, about 40 psychologists, about 20 or 30 or so master's level folks. We've got about 20 different offices up and down Florida, and a couple of offices in Alabama and one in Indiana. So that's who I am. I want to start off talking today, opening this up, and because you've heard about all these different alternative practice models, and IPA, MSO, DID, PSO, whatever the names are, and they get a little confusing and a little overwhelming. And part of it is, for you guys, is how does this apply to me? And what we want to talk about today, what Vince and I are going to talk about today, is this is a model that you can tap into. This whole purpose of what we're going to talk about today is for you to be able to utilize one part of it, two parts of it, or 20 parts of it. But it allows you to access an alternative practice group structure without having to be an employee, without having to join as a member, without having to go through the merger process, the MSO process, the lawyer process yourself. It allows you to do that. So what we're going to talk about in concept today is how is all this meant for you as soon as this thing gets up and running and is rolled out. But this is directly applicable to everybody sitting here today. Where this came from, where this whole model came from, and what Kevin was talking about is that this model, this MSO model, it's out there. This is like not new. Dentists use it, cardiac surgeons use it, cardiologists use it. I mean, it's out there. This is not a new concept. However, it's never really been done on a global or a national scale for psychologists to give you guys the benefits of how to enter into an MSO or become a member and utilize some of the pieces of it. It's really never been done on this level of scale before. So it's new for us. It's not new for anybody else. Where it came from is both for Vince and I, and Vince will explain a little bit about who he is in a minute when he gets up here. But it came from what happened as our groups grew. And I started off in 1998 with 4 people, then it grew to 6 people. All I wanted to have was 12 people, and then I could back off and retire and let everybody else do the work. We got 12 people, it was like, oh my God, I'm working harder now than I ever was. Now I need 20 people, if I could only get to 20 people. So in the course of growing, all these things had to change and happen, and HIPAA, EHR, all the stuff that we're going to talk about in the next hour or so, had to happen for me to sustain the viability of this now has gotten to be a relatively large group. So through our pain, our what's worked, the success, the failures, we've developed the infrastructure that allows us then to talk about how do we take what we have for our group and give it to all you guys in a way that should be a stable platform and can sustain the growth and can shoulder the growth of something that grows way beyond our 100 people or his 100 people or whatever. So that makes sense? So back in terms of our group, where it came from, the concept is multidisciplinary. We do everything in our group: psychiatry, neuropsychology, psychological testing, individual, family, whatever, neurofeedback. We do transcranial magnetic stimulation, one-stop shopping. And you're going to hear about the benefits of that, how it's accrued to us as a group, and then again, how do we share that with you all at the end by allowing you to join this piece of this MSO that we're trying to build. So part of our group growth has been, as you have psychiatrists, as you have testing, each one refers to the other one. The psychiatrists need testing for differential diagnosis. Is there issues of malingering? Is there issues of cognitive problems, mild cognitive impairment versus anxiety? So there's this internal referral system, which is kind of critical because it goes beyond just having the psychologists. Psychologists are great. Psychiatrists have a caseload of over 500 patients. Right? They can sustain sending referrals to psychologists and help you grow in a big way. The psychiatrists love having the neuropsych testing, love having the psychotherapists to refer their patients to in-house. And so again, as I mentioned, we're in about 20 locations. We even have kind of a partnership sister location in Trinidad. We do schools, mostly outpatient, but we're involved with schools, sports training facilities, psychiatric hospitals. We have a program in psychologists working full-time in a psychiatric hospital, rehab hospitals doing stroke and orthopedic rehab, psychiatrists doing that as well. So lots of different areas, lots of different things. I think I'm done.
Yeah.
All right.
Thank God. Don't go too far. So one of the things you'll notice talking with Jeffrey and I is we love doing what we do, love being in our practices. So feedback we got from New York was, okay, we're at SLC, we talk way too much about our practices, not about what we're trying to do with this MSO. So you heard early this morning what our practice is like. Same thing, we're a multidisciplinary practice in southeastern PA. We had two significant growth stages. We started very small, 4 or 5 psychologists back in the 90s. Between 2000 and 2011, we grew 11% a year, which we thought was terrific. And then we leveled off, and last year we just went gangbusters, buying 2 practices and increasing our PCP co-located offices substantially. And so I mention that because how we both feel is healthcare is changing so rapidly right now, and our belief is indeed bigger is going to be better. Bigger is going to be needed out there in healthcare. And you could do it the way we did it, but that takes years and years and years, and lots of mistakes along the way. This MSO idea is us to be able to provide to psychologists the backroom operations that if you choose, you can get bigger quickly with less mistakes. So bigger is better, obviously. We believe that. If you don't believe that, that's cool. But we think that's the way of the future. Being bigger, it drives influence with payers, drives it substantially. If you've ever heard of tiering, it's coming. It may already be with you that a payer may refer to their Tier 1 network, which means patients have a lower copay, and the provider gets more referrals. But to be in that Tier 1, you got to do some things as a provider. You got to meet some criterion. If you don't, you'll still be in Tier 2 or Tier 3, but it's a higher copay, and you know patients will go where their copay is less, and you'll get less referrals. The other influence that we've certainly realized is with some insurers starting to do this value-based contracting, other incentives they do as long as we meet their requirements.
You know, Vince had mentioned, and the slide was bigger is better. Now, there's solo practitioners, raise your hand. How many solo practitioners are there? Solo's about half, a third or so. Group practice folks, people in groups, it's about split. So it's about a third or so, and then there's other people here that are hospital employees or other things, other types of practice, right. So there's nothing wrong with being a solo practitioner, especially if you're self-pay, especially if you have a niche, and especially if you have multiple referral sources to keep you going for the rest of your life. The issue is over time that the world of the solo practitioner, in terms of being able to sustain a viable solo practice and make decent money on a full-time basis, is just shrinking over time. There will always be a place for sophisticated, niche practitioners that have a specialty area. But if you're if you're doing general psychotherapy and individual counseling and some family counseling or couples counseling or whatever, there's so much competition from other fields that the options of making a good living shrink. So bigger, there's lots of things that we're going to talk about today where bigger drives a lot of really good things, and in fact, it makes the field really exciting, as opposed to, oh my God, life is going to come to an end for all of psychology. We're growing. I mean, there's good things about being bigger. The downside of being bigger and the downside of being a psychologist in general is this slide that you see, right? PQRS, EHRs, encryption, BAA, PCI. Anybody raise your hand if you take credit cards in your practice, right? Does anybody use a computer or do you use a swipe machine? Raise your hand if you use a computer, right? As opposed to a swipe machine. If you use a computer, you have to have that computer has to go through PCI compliance. There's a whole list of questions that you have to fill out and follow. Otherwise, you're out of compliance with PCI, and you are in big trouble. BAAs, you've all heard of, business associate agreements. There's all kinds of things that are pretty scary out there that, for the most part, when I was a solo practitioner, it was like, oh yeah, I'm sure, I'm a really good clinician, they're paying me okay, I'm writing my notes okay, leave me alone. But in this day and age, with ACA and all these other issues that are coming up with Medicare, you can't really, everybody knows you can't really put your head in the sand anymore. One of the things about an MSO is that we take care of this stuff for you so you can sleep at night. And if you can't sleep at night now and you don't have these things in place, that's probably a good sign. If you're sleeping fine at night and you're ignoring all this stuff, then, theoretically at one point, it can come back to bite you in the butt. So these are all the things that we are going to deal with as a management service organization for you. And the concept of, and I know Kevin's talked about this, but let's get to the nitty gritty, right? What is this going to do for you? What's the point of this? The whole idea is that the management service organization is an organization that is a group of associated members whose job it is to provide all the back office administrative support to do everything for you. Deal with PQRS, with APA's help as necessary, deal with an EHR, deal with billing, collections, whatever else. Give you all those options to deal with everything except see your patient and write your note. So the concept is, if we do everything else, then you see your patient, you write your note, you go home and sleep at night, or maybe you see 3 or 4 more patients a day because you have the time to do it now, that you're not worrying about billing and collections and appeal and why didn't they get my claim and all this kind of stuff. So the idea is we provide, the group as a whole gives you benefit by providing all the administrative support, all the back office support, and in the process, it acts as a large group, in effect, that can do many different things for you, such as deal with insurance companies, develop quality assurance plans, develop clinical integration strategies for you that you can tap into, negotiate with insurance companies, all kinds of stuff that can happen. The idea being that we do all the back office stuff for you that allows you to do marketing, to do growth development, to develop new programs and see more patients so that you don't have to worry about all the stuff that you would normally have to worry about, okay? So
One more.
Okay, so the MSO, because of the large size of it, there's economies of scale. There's all kinds of economic benefits to doing things in a big way. Negotiation of rates, cost savings, because it's so big and everybody's a member. You get discounts that we're going to talk about. We actually have people already on board and large companies already on board to give us discounts to the group members. Being able to negotiate with health plans and that kind of stuff. It drives a power and influence that you can't possibly have as a solo practitioner, a group of 10 or a group of 15, or even, as I was talking about earlier today, even a group of 70 psychologists. If you don't have the multidisciplinary aspects of it, it still makes it very difficult to negotiate with insurers. Being part of this large multidisciplinary management service organization gives you a level of credibility and influence that you can never have as a solo practitioner. Okay? You're on.
Okay.
Sorry.
Take a deep breath. I know, I need it, hearing Jeffrey talk. So this MSO is going to provide a menu of options that people can buy into, one or all of them, or somewhere in between. So just take that, if you have a group practice, things are operating fine, terrific, but there might be some aspects you need help with, HIPAA compliance, for example, and that could be a menu option that you would purchase from this MSO. Or you might want to do, and we'll go through, a couple slides later, we're going to talk about the various ways that, well, for lack of a better word, the challenges that we face getting larger, that you guys already face or will face, that we believe the MSO can help with. One of the ultimate dreams, I guess, with this MSO is to develop, as Kevin talked about earlier, clinical guidelines and care standards that would let us negotiate for those who hit that level of agreeing with our clinical guidelines or working with our clinical guidelines and standards to negotiate with insurers. We negotiate, we can obviously maybe influence some rates. But we need to meet those clinical integration definitions. I think there are about 11 of them that we talked about, or Alan did. You may want to take a look at those slides. I explored that earlier, talking with some other group practices. Didn't quite work out, but it's still the possibility of achieving the same type of level with this MSO. With the goal of clinical integration standards, if we all can meet that, we then harvest a shared saving relationship with payers. The reality is, there's not a lot of money in the behavioral health side. I think you all know that. It's not a news flash. There's not a lot of money here. But there is plenty of money out on the medical side, especially if, as behavioral health experts, we can influence someone's overall health by bringing interventions to them in the PCP practice, in the cardiology practice, in the oncology practice. We can help create a healthier patient through our interventions. A healthier patient means they cost the insurer less money. Well, if they cost less money, where's that money going? In whose pocket? Well, I wouldn't mind 10, 25% of that. That's the relationship we're going to establish with the insurers. That's how we expect to push this out.
Can I use this as an example? For instance, ACOs, accountable care organizations, and managed Medicare systems, the Medicare Advantage plans you guys have heard about, they're all based on the doctors that are providing, the physicians that are providing treatment get paid based on how much savings they make. So if a patient on average costs $20,000 a year, if a patient with a medical condition costs $50,000 a year, and as a psychologist I can provide treatment that will bring the cost down from $50,000 to $40,000 a year, $10,000 per patient times 10,000 patients is millions and millions of dollars, and that's how those doctors get paid based on the cost savings. If I can prove that our services help bring the cost down, which drives money to those physicians, then we're going to go back to those physicians, theoretically, and say, I want 10%. You wouldn't have those savings without us. 10%, 20%, 30%. I want a piece of the pie. And it puts us in a very different role with these large physician groups, ACOs, managed healthcare, and in other areas that are coming on in the next 5 years. Now, this hasn't happened right yet. There are discussions that are ongoing with this right now. It hasn't finalized yet. But as an MSO, if we can pull that off, and then we set up a system for what kind of services that we're going to deliver to what kind of physicians to show those cost savings, and you're part of the MSO, guess what? You're going to be involved with that. You're going to be involved with those physicians. You may get the benefit of some of those savings, money that's not fee-for-service money. So that's just an example of what Vince is talking about as being part of an MSO that is in the process of developing integration guidelines and new systems of service that drives more money, cost savings, and ultimately more back for you. Okay.
So the MSO is meant to be a tool that helps providers grow by using the resources established already and vetted by successful groups. We expect an increase with this, an increase of value and profitability that everyone shares in. So we're going to jump on some slides that are sort of the non-clinical business functions that we believe an MSO can help people with. Again, think of it as a menu. It's not all or nothing. There are different areas that groups, solo providers struggle with. We've seen this. I've already had today a number of people come and ask me, what EHR are you using? And we'll talk about that, but do you use an EHR should be the first question. And if not, you will be using one probably in the next couple of years. Finding one that's built specifically for behavioral health would be great. One that does e-billing and posting, calendar scheduling, e-prescribing, meaningful use, have patient portals. We have both explored a number of different EHRs, and I guess the first criteria is you want one that integrates fairly well that list there. Do they integrate between their calendar, scheduling, note system fairly well, or is it kind of clunky? How well is that integrated with their billing? Those are the little things that make a big difference down the road. So the other piece I want to mention, I don't have up here, is the EHR prepared to work towards interoperability, moving and sharing data, obviously within your practice, but also between your practice and the medical side. That's going to be the key to the future here, is how do we share our information? If we could get our information over to the medical and get it from the medical over to us, that's a powerful tool to drive down costs. It's a significant hurdle.
The EHR is the backbone of everything, in effect. The sophistication of the EHR, there's ones that are very simple that just send out bills and you post payments. That can be an EHR. There's more sophisticated EHRs that integrate scheduling, calendars, sending out patients emails 2 days in advance automatically. There's ones that you can get data analytics out of so that you can look at and say, geez, I wonder, all my patients with a major depression diagnosis, what's my average number of sessions that I do with them? What's my average treatment modality? Am I doing CBT? Am I doing DBT? Am I doing whatever? The more sophisticated you get on an EHR, the more unbelievable bells and whistles and things it can do to help you drive your practice and show outcomes to the payers and to everybody else. The issue with the MSO, same issue, is that as a solo practitioner, you can't afford these sophisticated EHRs. You can't even have the time to spend dealing with all the different bells and whistles and how do you set it up and the templates and customization and all that kind of stuff. The idea is the MSO will have an EHR that you buy into, and then your practice gets the benefit of that, probably at a much lower price. But then it allows you as a solo practitioner or as a small group practitioner to get the benefit of what the bigger guys have, but without having to pay an arm and a leg for it.
Okay, we're going to keep moving because we got. I'm sure there'll be lots of. We want to make sure we leave time for questions. Other huge issue with any practice, large or small, is revenue cycle management. How well do you do at collecting? End of the day, that's going to separates the successes from the non-successes. I've always been struck about how poorly providers deal with this, to be honest with you. Do people who run groups, do you know what your collection rate is? If I ask y'all, could you tell me, I collect this in 30 days, 60, 90? Absolutely. Good. And it's amazing the amount of people that don't know and don't know why. And there are little adjustments. If you can increase your AR by 2%, well, you reduce it by 2%, that's a substantial savings. Can you use the EHR for that? One of the things that Jeffrey and I have learned as, he called me about 10 years ago and said, I run this practice in Florida, and I'm just trying to figure out if I'm not doing something right. And that's how the telephone call went. We developed years of talking together and understanding from each other what works, what doesn't work. You guys could figure this out on your own, and I'm sure some of you already have, but I think it's expanding so rapidly, the healthcare changes. We just wanted to offer another option to help you get to that level you may want to get to much more quickly. Just one or two things about revenue cycle management. I have 10 points to talk about, but coding. How do you maximize your coding? Does everyone, Geoff told me earlier today, there's people out there who don't understand the 90837, 90834. My response is, really? If you're with psychiatry, are you maximizing the 99213s, 99214s, plus the 90833s? And are you doing it all without fraud, but you pushing the limits there? Make a big difference. Okay, we'll jump on to IT as another great challenge. This is you.
Okay, so again, what we're going through the backbone of what an MSO does that you guys as a group, as solo and small group or even large group practices need to have in order to run a practice. Again, solo or even group. If you're on the FPA, the Florida Psychological Listserv, every single day, does anybody have an idea what EHRs are people using? What's a good encrypted system? Is Skype HIPAA compliant? What's a good phone system to use? How do we do telehealth? What kind of video system? Those are the questions that come up 3 times a day, every day. And everybody's got a different opinion about it, which is fine. And some people have done some great research. But part of having the MSO is having an integrated, somebody's done the research for you. We've developed an encrypted email system, or we use an encrypted email system and know how to use it. And we've done the research to show that it works, it's compliant, here's how it works. Texting, texting, there's issues of HIPAA compliance in terms of texting systems. We have our VoIP phone system actually has texting built in from the computer. You can right-click on the person's name, anybody in the whole practice, and you send a message and it sends a text message to their computer or to their phone or wherever. Again, IM, secure video. So this is the IT piece is a solid, huge piece of how do you operate in the 2016, 2017, 2018 years here.
I just want to mention, people have heard of ransomware, the viruses out there. That should keep you up at night. That's very, very scary stuff. Just in terms of educating your staff about how, what to click and what not to click, with everything from attachments to, is your system even set up that way IT-wise to be secure? When I was looking at various EHRs about a year and a half ago, I called a lot of other practices throughout the U.S. who I thought was using the EHR I was interested in. It was very interesting hearing from them about what they were doing about security. And again, it sort of blew me away, the naivete they had about we're okay, we're secure, i.e., yeah, this thing's based in the cloud, so I don't have to worry about security. Right. No, that's not accurate. So, go ahead.
No, so ransomware is when you download something and all of a sudden your computer goes black and there's a little sign that pops up that says you are now unable to use your computer or access any of your patient data unless you pay us $10,000. Here's the place to send the check to. A bank in Antigua or someplace like that. It is happening.
Bitcoin. Yeah.
Using Bitcoin. That's right, and it uses Bitcoin. It is rampant. I mean, it's happening 3 or 4 times in our town. It's happened to psychologists, other doctors. The risk of running a business solo. If you have a secretary, and your secretary has email, she clicks on the wrong thing. It's not like this is only going to happen with a large group. If you have 2 psychologists, if you have a secretary or whatever. So everybody can go out there and find their own piece of phone, their piece of texting system, their email system, an encrypted system, and which malware do you want to use and which antivirus. You can all do it. The idea is the MSO brings it all to you so that you jump onto a system that's already been vetted, that's already been researched, that has been in operation working for 10 years. That's the concept of what we do.
And by the way, these hackers are going after healthcare practices. So on the black market, a healthcare record gets the most amount of money out there because it's all the information they need. And they're going after the small, mid-sized practices because they're just not secure.
Right. Yeah, we've had multiple conversations with our IT guys, with Vince, about somebody's using our EHR system at home and they're going to leave it on by accident and their 14-year-old kid's going to come along and say, oh, it's already logged in or whatever. And all of a sudden you've got a breach of once you hit 500 patients, you're done for. You have to call the Department of Health. You have to put an ad in the newspaper saying that I've had a breach. There's fines it's like ridiculous. The risks now are so large that if you're not aware of them and you're not doing something about them, then you've got your head in the sand, right? I got 4 slides here, more head in the sand slides. The HIPAA piece and the high-tech piece and the compliance piece is, in this day and age now, it's critical. It's happening more and more that people are looking at these breaches and whether you're compliant or not. And now the government is doing, they're doing audits, HIPAA audits now, not just waiting for you to have a breach and then talking to you about it. They're doing a HIPAA audit like they do a chart review or a complaint or whatever. You don't even have to have a complaint. So you're not supposed to be able to read this. If you could read this, you've got better eyes than anybody. I'm showing this to you, and I got 3 slides, but this is my company's HIPAA compliance, the skeleton of our HIPAA compliance program. I hire a HIPAA compliance outside consultant to come to our office, do an audit of our entire office, our fax machines, our email systems, where secretaries are sitting, where patients can see the screen or they can't. They audit everything. And then they come back with a plan and they tell us what we're doing wrong. And they tie it, if you see on here, these are the standards. These are the federal rules that it comes from. So every standard is tied to a federal rule. This is what the specification is, and this is whether or not I meet it or not. And I have to show improvement on this. You're never going to be 100%. But if you look at, you'll see the 4th slide of this. This is the 2nd slide. All right, this is more stuff. There's, I think, 85 items on here. There's the 3rd one, and here's the 4th one. All right, so I think January of 2014, I think we were here, 23, and we improved within 6 months up to here. Once we hired the guy, he came in, you need to change this, you need to change this, and it's tied back to a system. So if we have an audit or we have a breach, I'm not saying that, I don't have one, I've never had a breach before. That's negligence. That's when you're going to get fined. But I can at least say that I've got a system, I've got a HIPAA compliance guy, we've tied it to every single law and section of the law, and we're making progress on improving all these areas. If you don't necessarily have to have this, but raise your hand if you have a HIPAA compliance system in writing in your practice. Right? Okay, maybe a third of people, all right? Are you tracking every single breach that happens? Are you tracking everything? Have you hit most of these guidelines? Are you tailoring it to the federal law? This is part of an MSO. This is part of what you buy into, so that you don't have to do this. We're going to send somebody to your office to do the audit, to come back, and here's what you need to change. And then if there's a breach, you may not be in 100% compliance, but if there's a breach, what you need to show is that you're aware of it, you're making changes to it, it's not perfect, and then you're going to be okay. You'll have to make some changes, but nobody's going to fine you for that. So that's part of what comes with the MSO. Again, another piece of the backbone of the infrastructure that the MSO can provide to you so that you can sleep at night.
It's almost 2:30. So
Where do we have a half an hour?
Oh, we got
We're almost-
questions.
we're almost done.
So we talked about EHR, revenue cycle management, IT, HIPAA. Practice management is a level of service that the MSO will offer. Do you know, as you get bigger, what are your, the MBAs like talking about KPIs, your key performance indicators? What are those things that your practice is doing that's saying it's successful? Do you have them listed? Do you know what they are? How about just simple stuff like managing staff, procedures, processes? Have you figured all this out on your own? Do you talk to others about it? We talked about building and be able to mine data. That is absolutely huge, as we've heard. Utilization outcome measurement. And we talked about establishing those relationships with payers. One of the things this MSO will offer you is our experience with dealing with payers. What gets you in the door? What gets them listening to you? The other piece we'll offer is consultation. So the business consultation, it's certainly wider and deeper than just practice management, daily practice management. Talk a lot about culture. It's one of the big struggles, not struggles, I would say challenges in our organizations as we get larger. How do we get it so it doesn't feel like a mill? How do we get it so that everyone in our satellite offices still feel like they're part of something meaningful and they count? Because you get larger, that can all fall apart very quickly. I've seen organizations where that happens. Do you actually have a vision and a strategic plan or not? You're just winging it every day. Do you have a succession plan? What's going to happen when you retire? Is things going to fall apart? Are you going to give it to somebody? Are you going to sell it to somebody? Do you have any idea what your practice is even worth? The other piece is about business, managing versus leading. In some ways, very different concepts. Legal, I heard about earlier, 1099 versus W-2. It's always, what should they be doing here or there with either one of those? What are good contracts to have in place? Do you have non-competes? Do you have non-solicitation? Do you have processes set up to reduce your exposure and manage your risks while also be willing to take risks? Because this is all about taking risks, which makes it fun. Actually, I was going to comment from this morning hearing Kevin and Alan talk. If I listened to lawyers enough, I'd never open a practice because they scare the bejesus out of you. But Jeffrey and I like taking risks and just manage the risks well. Accounting pieces. We talked about AR, but beyond that, reconciling. So what goes in a bank account is actually pretty close, or maybe exactly what's in your EHR system there. Most small businesses have, unfortunately, experienced some form of embezzlement. Do you have your systems in place so that's not going to happen? We deal a lot with cash, and it can be awfully enticing for someone to throw some in their own pocket. What are your systems in place to prevent that? Financial. I mentioned profit margins. Do you know what your profit margin is? What is a good profit margin? It's okay to have a profit margin, but what is it? Geoff and I both bought some practices in the last couple of years, and we're struck by, and that's okay, but part of being a smaller practice is you don't know what your profit is, because everything's mixed in together. Maybe the car. Certainly, are you paying yourself fair market value, or are you paying yourself whatever's left in the month there? As you get bigger, these are considerations. Talk about valuing your business. Valuing your business is directly related to how much profit you have. And of course, the other thing with financial, we hear this all the time, setting reasonable salaries. What should you be paying an office manager?
So from a business consultation model, people and psychologists in general are just very poor business people. We don't get trained. Simple example, does anybody know what percentage your rent ought to be out of your gross revenues? What is the benchmark for what's an appropriate, to run a viable business? How much rent should you be paying as a percentage of your gross revenues? Anybody have any ideas?
No, but what is it?
Right? I mean, that's a simple. And I learned some of this. My father's an accountant. My brother's an accountant. And I didn't learn this until they came onto the practice as we grew, and they said, "Oh my God, what are you doing? Look at how much rent you're paying, you idiot! You're going to go out of business next year." I said, "I don't know. I've been here. I've been paying rent. Seems reasonable to me. I can still pay. I can still go on a vacation once in a while." And from a business perspective, for instance, a good percentage of rent, a good benchmark is 5%. If you're paying more than 5% of rent to your gross revenues, then there's kind of a problem. You know, and 5, 6, 7% is okay. If you're at 10%, then what that tells you is, number one, either you need to go to a smaller place because the revenue that you're generating can't support the building that you're in, or you need to expand what you're doing and expand out and make that other space that you've got revenue producing. So that's just one little tiny example of a business, whatever. What are we doing?
GPOs.
Okay, good. This I'm going to go over quick. Part of having the economies of scale, you guys have economy of scale in high school, right? For macroeconomics or microeconomics or whatever, you've heard of economy of scale. Well, what that means is when you have a large group, you can go get discounts. It's pretty simple. So we've already, before we even have this thing up and running, we've already gone to different organizations who have said, yes, this is a great vehicle for us to be able to market our goods. We like the idea that you could represent 100 or 200 or 1,000 psychologists or whatever. We'll give you a discount if you can do that. So we've spoken to Payor already, and they've already told us they'll give us a 10% discount on all their testing, and even 5% discount for tests that they distribute but aren't even their tests. So that's a benefit to you right off the bat. 10% less on psych testing supplies. Depending upon how much you're doing, neuropsych testing or whatever. For us, it's substantial. I spend $5,000-$6,000 a month on testing supplies. It's ridiculous. We've already talked to Staples. Staples has already given us a 10% discount once we get this MSO up and running. What does your paper cost? How much does it cost for you to buy a computer? What does it cost in office supplies for you, pencils and whatever else? When you look at that as part of a business, then you'll see that can be substantial. You guys have heard of impact testing for concussions? They're on board with us. So the GPO is a group purchasing organization that gets us discounts. So it offsets some cost, and it allows you to operate your business at a more profitable margin. Credit card fees, anybody ever looked at their credit card fees? Mm-hmm. What do they tell you? I'll give you this credit card for 3%, 2.8%, right? Is that normal? Anybody have less than 2% or 3.3% or whatever? All right, so if you actually look at, what I would suggest to you is go back and look at what are your total fees against how much is totally billed on your credit cards. Doesn't matter what they tell you, if it's 2.8% or 2.7%, because of the way that credit card systems are set up and all the extra fees they kick in there, it will be well over 3%. Well over 3%. We've been able, because of this, the MSO and the size of our business and the size of this, we've been able to negotiate less than a 2% rate. And that's 2% total, including all fees. That's a 50% discount on the cost of doing business for anybody that uses a credit card. Again, a benefit to the membership because of the size of the economy of scale. I'll shut up, go ahead.
We'll skip that. You already know what's going to, we think, make you attractive. Jeffrey, so we're talking about perhaps a new dance. Partnering with the payer. You heard my talk earlier today. I think that's the future. We partner with them to bend the healthcare cost curve. We're still, what was it last year, 6% increase in premiums across the nation. When our rate of inflation was under 3%, it's still double. And it's still, the cost curve is still out of control. They're talking about this year being double digits again. So the system's broke, healthcare is. The only way it's going to get fixed, I think, one of the ways is behavioral health partners more with the payers. What do you guys need to help bend the healthcare curve? And that means bringing behavioral health to the medical side. We negotiate rates, participate in innovative programs, sit on advisory committees, and so forth. Those are the pieces we're talking about that's being offered in the MSO. That's just a repeat. And you want to go through these real quickly?
Okay, so at the very end here, we're coming to the end of this. So you understand the MSO is an infrastructure that you tap into that you don't have to develop on your own and have the pain and time it takes to put it together yourself. So these are all the different components. The idea here is that you pick and choose which pieces you want. Maybe you want the phone system, maybe you don't. Maybe you want the billing system, maybe you have a great billing system. You pick and choose from the menu of all the things that we've mentioned, plus there's about 20 more. And you basically contract to have those services provided. That's the management services piece of the MSO. You're not obligated for any of that, to take all or none of it. Keep going, next one.
Well, there we go. So we're at the end.
Oh, okay. So there was a piece about, you're not, basically it makes you part of a large group, but you're not an employee. It's almost like a Walmart or Sam's Club, not Walmart, but Sam's Club, where you pay for the membership pieces and you get Costco, we got Costco. It's more like that in some ways, and there are going to be some questions about legal issues and liability that are going to come up as questions, and Kevin can help answer some of those. But basically, you're a member. You're not an employee. You haven't joined my group. You haven't signed a contract with me to become an employee. You are a member.